Okay, I'm somewhat embarrassed by Rupert's introduction. I do a bit of hand surgery, and I've been very privileged to work at a unit where I see some really interesting cases, and a unit where people keep my feet on the ground at the same time. And I'm also very privileged to be invited as a joint thing here with Polpe and the Polvertaft. As Rupert said, I was previously a fellow, and I have great fond memories of Polvertaft. So we're hoping we'll be able to put on a whole series of webinars together with the Polvertaft on kids' hands. And we obviously started with an amazing one on the embryology. And if you haven't watched it, please do, because it is absolutely superb. I'm going to be talking about genetic syndromes. And a definition of a syndrome is a group of signs and symptoms that collectively indicate or characterize a disease. In England, at least, it used to be the thing that used to be written on the notes was funny looking kid, which was entirely inappropriate and certainly not politically correct. But basically it was saying, this is a child that doesn't look quite like the norm. This is a child whose features are out width of the two standard deviations from what we'd expect. And actually genetic syndromes are quite common in congenital hands, particularly in radial ray dysplasia, in syndactyly, and in all of polydactyly. However, if you think I'm going to talk about all those, and those of you that know me know I can talk quite a long while and for a long while, I am still not going to talk about all the syndromes that you can get. And I would love this to be my book, but it isn't. It's another Smith that produced this book. And it's probably one of the best known books about all the different recognizable patterns and syndromes you can get. It's got a lot of pages because it's got a lot of syndromes. But I'm a surgeon. I'm not a geneticist, and I don't know all the expert ideas, so don't expect to get all the answers from me. I will not be covering every syndrome that you're likely to see. There are too many of them, and I will be talking for so long you'll all be asleep and woken up the next day. But I do think it's really relevant. It's relevant for a clinician to have an idea about syndromes, partly because we're all doctors and we might be surgeons, but it doesn't mean we've forgotten our brains and how to think. And it's a real eureka moment when you suddenly recognize a syndrome and you know what's wrong with the patient. And that's nice for you, but actually it's really important for the family. And when the family come to see you, they not only want to know what it is, but they want to know, why did it happen? Is it going to happen again to me? And, you know, that's always of concern. And it's relevant for the child. And one of the other things that the parents want to know, particularly when there's a very visible difference of any sort, is there anything else wrong with my child? Are they going to develop normally? Is their brain going to work? Are their internal organs all right? And this is always a source of concern. And having a little bit of an idea of what other problems there might be means that you can look for them. But it's also important for overall hand function. If you've got a child whose brain's never going to work very well, their hands are never going to be brilliant. However good they look, they're only going to be able to do as much as their brain will allow them to do. It's important because of anaesthetic risk, because there's very little in hand surgery that is immediately going to cause the loss of life to a child. A few tumours, but it's pretty unusual. So most of the stuff in hand surgery you're dealing with, you're weighing up risk of operation with benefit of operation. And if you don't know the anaesthetic risk that may be involved, then you can't really weigh that up. It's also important for surgical results. And certainly here in the UK, we're very keen to get outcomes. But for outcomes, you have to compare like with like. And comparing a complex, complicated syndactyly release with a simple, incomplete syndactyly is not even apples and pears, it's apples and pomegranates. So what about some people out there might not have access to genetics, and you may not be able to call upon a geneticist? Well, the first thing I'd say for even us that do have, and I didn't realize this till I was a consultant, not all geneticists are the same. Now that might be really obvious, just as not all surgeons are the same. It wasn't obvious to me, and I figured if I sent a child to a geneticist, they'd know what was wrong. And some of them do, and some of them don't. And some of them have more of a knowledge of upper limb problems, and some have less. But all of them work on pattern recognition. So whether you have a geneticist, access to a geneticist or not, you can pattern recognize. You just need to keep looking for it. You need to use your eyes. You need to examine the patient, and you need to look at hands and feet. And if you look at what the geneticists look at, hands and feet are some of the main things they look at, together with mildly dysmorphic faces. And I want you to look at this child, which you can see a bit of in here, and I'm hoping that you'll all have worked out what the options are for what this might be, and got some idea of that, so that when we come to it later, you'll have already worked out the answer. That'll make life easier. So what about general principles? Well, if you start finding the child's got lots of different things wrong in different systems, this is quite likely to be a genetic disorder. If you find multiple limbs are affected, and particularly bilaterally as well, again, it's much more likely to be genetic and syndromic. And this, of course, is going to have implications for future children. Remember as well to take a family history, because there may be a family history which will indicate a genetic problem probably. And consanguinity will increase the risk of particularly autosomal recessive disorders. And look out for those subtly different features, the slightly low set ears, the slightly wider or narrow spaced eyes, a nose that's very flat or upturned, a long lip. So what are the exceptions to multiple limbs being genetic in origin? Well, probably the main things are amniotic band sequence, which of course may involve amputations in all 4 limbs. So you can have 1 to 4 limbs involved, you can have multiple amputations. And the other thing's trigger digits. And we all know that trigger thumbs you quite often see bilaterally. But most other things have got a genetic origin. And there's even a little bit of a query about trigger digits, because of course, is there a genetic predisposition upon which the developmental aspect comes into play? Because we certainly see an increased risk in brothers and sisters of those that have trigger digits. So for those of you who aren't going to read Smith's book, there's 2 much more easy and surgeon-friendly ways of trying to look up syndromes when you see a child that doesn't quite fit the bill. And one of them is Wee Lamb, again, I don't know where he fits in the time to do this, has produced the OMT app, OMT being Oberg-Mansky-Tonkin, meaning the classification of congenital hands. And you can get this app on the App Store or Google Play, but don't just look up OMT, because if so, it will give you a money transfer app. And much as I'm sure we would like some money sent to him, that isn't the idea. And you need to look up for the congenital hands one, and you can get these on the IFSSH website, so you can look up through there if you wish. The other very good book, if you want to invest and spend some money, is a book by Ghazi Rayan and Joe Upton from Boston. And I thought years ago about writing this, and they beat me to it, and they did a phenomenal job. And they've looked at different hand abnormalities and the likely syndromes associated, and some of the less likely ones, not all of them. But they give you some really good information, and it's quite a good reference book. Or if you're a bit weird and you just want to read it just for fun, you can. It's quite nicely written. So you might say, well, I just see simple cases. I don't need all this. You know, I'm just seeing normal stuff. Oh, no, polydactyly, for goodness sake, you know, I can manage that. I don't need to worry about knowing about syndromes. And I'm sure all of you will have seen the little floppy, soft tissue attached extra digits on the ulnar side of the hand that you see very commonly in the Afro-Caribbean community, often with a family history, often bilateral. And you'll have your own way of taking these off, but they're dead common and they're not necessarily associated with anything. But the solid type, the type that are either a whole digit or got a metacarpal or phalangeal attachment, they're more common in the Caucasians, and they are much more likely to have some sort of genetic association, often syndromic. And indeed, we looked at ours, and there was a significant syndromic correlation with those particular had more than three or more limbs affected. So just because you think you did simple stuff doesn't mean you won't miss syndromes that are important not to miss. And when we looked at ours in Great Ormond Street, and fair enough, we have a specialist group, but some of those are from relatively normal hospitals and appear normal when you first see them. All of these were syndromes that we saw. And they hadn't all been diagnosed. In fact, the majority had not been diagnosed when they came to us. And they had signs that these were syndromic, some of which it was quite important to make that diagnosis. This is important to make a diagnosis for the purpose of the family. And that's because quite often they'll be expecting another child sooner or later. And particularly if they don't think there's much wrong, there's just a little extra digit you've taken off, they may well proceed with further pregnancies. Now, some conditions, the way it looks to you and I doesn't fit, it varies within the genotype. So the genetic mutation and the appearance do not always match. The phenotype varies within the genotype. And classically for this is Holt-Oram. Now, Holt-Oram syndrome is related to a TBX mutation. And you'll often see bilateral thumb hypoplasia. It might be quite mild. It may just mean that there is an IP joint crease that isn't there, or a very mild thumb hypoplasia. And you can see that top view, there's the IP joint crease isn't very good. There's some phenohypoplasia, but nothing that is the end of the world, even in the bilateral case. And they have associated heart defects. And this is classically an ASD or a VSD, and they're often ones that will spontaneously close. However, it isn't such good news, because just occasionally, because within that genotype, the phenotype can vary, the child may present with Triphalangeal and a radial clip hand. And that is a much more serious condition. And if you've had a family that you've been looking after and you haven't made that diagnosis and haven't seen someone and been advised that it won't necessarily turn out the same for the next child, you might end up worse or better because you might not be affected, then I think that's really important. There's also, what about children that are already born? And there might be a difference. So Madeline's is due to a SOX gene mutation. And you can get this with Lerivardus chondroosteosis, and they're obviously short in stature. And you get deformities, particularly the dinner fork deformity, like you can see in the top right. And of course, other children may be affected. Now, if you turn up with a dinner fork deformity, you're going to need some fairly major surgery if you're going to correct that. But you may have the option for a younger child that's affected to gene test them. You may be able to do earlier surgery. You may be able to do lesser surgery. You may be able to look at mum and dad and find out that they've got the deformity and that perhaps it doesn't need treatment because they coped very well with it without any major problem. And then, of course, there's the diagnosis that affects the child's prognosis. And this is particularly relevant when there's something that's immediately obvious, but not obviously pathognomonic, but it might affect how the child's going to do, or whether you're even going to operate at all. And classically, things like radial ray deficiency with Fanconi's anemia and black fan diamond anemia, or the radially deviated thumb, the hitchhiker's thumb as they call it, which is a classic Rubenstein tabi sign, or ulnar polydactyly if they've got BardoBeedle syndrome. So Fanconi's anemia, it's really important that you look to see whether the children have Fanconi's anemia. And the Fanconi Hope guidelines for the UK suggest that any abnormal thumb where you haven't already got another diagnosis, you ought to be looking for this with chromosome fragility studies that can be done on blood or they can be done on tissue, but blood is usually enough. For those of you that are going to struggle to work out whether they can get every patient treated that way, the ones that are more useful to see, look for very short stature kids. So anyone can measure how tall they are and plot them on a chart. Look for cafe au lait spots and look for microcephaly. And again, that's another thing that can be easily measured even in countries that don't have high income. It's important because these children will start off anemic and they'll later develop a pancytopenia. And with the pancytopenia, they will end up dying. However, of course, as I said earlier, families are inclined to have another child. Number one, you don't want to lose two, but also now you can test early and you could produce a sibling who may be a donor. And if you do a bone marrow transplant with a matched donor who hasn't got Fanconi's, then you should have normal life expectancy. So it is quite important to diagnose that one. Another one that can be a problem is black fan diamond anemia. And these patients typically have abnormal thumbs. So thumb hypoplasia of some sort, triphalangeal thumbs. And they have features of a very flat nose, low set ears, slightly small face. They're often a bit short in themselves. They're micrognathic. And they're anemic and often need blood transfusions for many years. They may need steroids to maintain their blood count, and some will need a bone marrow transplant. And then this is something you're very likely to see if you do any sort of congenital work. A patient with bilateral syndactyly, which is complex in the fourth web and maybe simple in other webs, associated with some very subtle features of a slightly narrow nose and slightly small eyes. You might not be very excited by that. But my classic one was a patient who was a teenager, and I said, "How are your teeth?" And the mum said, "Oh, he puts much too much vinegar on his chips at school." And it wasn't the vinegar on the chips that meant his teeth weren't very good. It was the fact he had oculodental digital dysplasia and his dental enamel was very poor. I'm sure the vinegar wasn't helping it, but it wasn't the primary problem. And this is an autosomal dominant condition. And they do have severe myopia quite often with it as well. And they can get detached retina. So they need to be linked in with the right teams. And then I'm hoping that you that are orthopedic can imagine that this is a lower limb, because then you'll probably spot the diagnosis that this is a pseudoarthrosis. This happens to be a pseudoarthrosis of the ulna, but as soon as you see a pseudoarthrosis, you're thinking, oh, could this be neurofibromatosis type 1? And obviously the axillary freckling doesn't always appear straight away. The cafe au lait spots usually appear relatively early and you need more than 5. Short stature is there. But I mean, I've had 2 patients who presented with an abnormal x-ray after a minor fall. And the abnormal x-ray, as soon as you look at it, you just know this is going to be NF1, and that's been how we've made the diagnosis. Obviously, it's relevant because they may have learning difficulties and they may need support through school. There is a risk, but the risk is much more so with plexiform neurofibromatosis that you get malignant change. And NF2, of course, you get deafness because they're the ones that get acoustic neuromas. As I said earlier, any form of thumb hypoplasia, you've got to assume is some form of radial ray dysplasia. So it doesn't have to have the radius missing. It can just be a bit short, or it can even be a normal length. And of course, when you're little, you're not going to see the carpal bones on X-ray. But a thumb hypoplasia, it comes within that spectrum of radial ray dysplasia. So you need to look for things that are associated. Now, if you look in some of the textbooks, there's about 2 pages of things. And most of those you're not going to get around to looking at or even know about. I'll have probably seen most of them once, but not necessarily a lot. But you've really got to look for the Fanconi's anemias. You've got to look for those hematological problems. Vacteral, which we'll mention at the end, is another one. Holler we've already mentioned with the TBX5 mutation and the thumb hypoplasia and the cardiac defects. So vacteral as well, of course, you're going to have cardiac defects, you're going to have renal defects. So you need to be looking for an echocardiogram, an ultrasound of the kidneys, maybe later a spinal x-rays looking for vertebral abnormalities. TAR syndrome, we're going to mention TAR syndrome later, but this is thrombocytopenia absent radius syndrome. And they have a thrombocytopenia that improves with age, but can be very severe to the extent that there is a risk of death. And Nenaga syndrome, which is one of the other more common ones, where they have micrognathia, they have very small chin, and they can be a problem, particularly with intubation. But they have horrible thumbs sometimes, and they can be very difficult to get thumbs that function for them. Now, again, for the orthopedics among you, you'd be very unhappy if I don't mention multiple hereditary osteochromator, used to be known as MXE, so multiple hereditary exostosis, usually XT1 and 2 mutations are occasionally 3. And of course, the really higher risk is the XT1 because they're a complete nightmare and they get much worse affected. There is a small risk of malignancy and it affects multiple bones. So these patients appear with big lumps, usually around their growth plates, so round DRUJ, round their knees, up proximal humerus, always seems to be in the wrong place, just where you don't want to be operating. And obviously they can get problems with growth of particularly their ulna and can end up with very short ulna and deviation. Another really important one to pick up, and you probably won't be the one picking it up, is Holler's syndrome, MPS 1, so mucopolysaccharidosis storage disease. And these patients get multiple triggers of their fingers, but because they trigger so badly, they often look like flexion deformities because they're just bent. They get carpal tunnel very early on and really, really, really severe. They won't complain about it because remember, children don't complain the same way about carpal tunnel. But they have respiratory problems, they have learning difficulties, and it's progressive because it's a storage disease. So you get progressive coarsening of their features. They also get cardiomyopathy. However, if they're diagnosed and they have an early bone marrow transplant, it helps intellectual function and their development hugely. Unfortunately, it doesn't help their musculoskeletal problems, so we are still going to be needed there. Now, I said about the prognosis for overall hand function, and this is a classic example of something where you want to pick up whether you're going to do something or not. Because the Rubenstein tabi syndrome patients, they have a very typical facies, and this is it. They typically have a short thumb and often a radially deviated one. It's known as the hitchhiker's thumb. Now, it's not the only condition with hitchhiker's thumb, but with these facies, it's typical. And they have learning difficulties. Now, you're probably not going to get a perfectly straight thumb. The thumb works reasonably well. And the question is whether the upheaval for the child who is developmentally delayed or having surgery is worth it. And certainly I had a child of 17, so it's not really a child, he's getting to adulthood, who had managed to eventually learn how to open a crisp packet, which he really didn't need to do because he was somewhat chunky. And I had a mallet finger that he couldn't cope with the splint on, and we decided to fuse his DIP joint. And within 24 hours of fusing his DIP joint, he put his hand down the toilet to pick up a toy that he dropped down the toilet. So with bandage, with wound, all down the toilet where he just opened his bowels into. So, you know, if you're getting that at 17, you can imagine at a smaller age, you've got significant developmental delay in these patients, and you may not want to operate. Another group with significant developmental delay are the Cornelia delange syndrome patients. And these ones, again, have a very typical facies, and they have a long philtrum. But the thing you really notice is the fact their eyebrows meet in the middle. So no werewolves. This is known as Ssyndramic. And they're also somewhat hirsute. They're short and have a very abnormal cry. It's called the cri de chat, and it sounds like the cat's being trodden on. And again, it may not be appropriate to be considering surgery unless you can do something that's going to make a major functional difference, but you're probably not going to. And they most commonly have like cleft hands or an ulnar longitudinal deficiency. So what about things that might affect anesthesia? Really important. Well, I said earlier about BardoBeedle, and this one child turned up at 16 weeks old, with the health centre having shut. So they weren't weighing the child because they were doing really well. They were born about the 90th centile and they were putting on weight beautifully. And of course, everybody's more worried that the child will failure to thrive. In fact, they put on so much weight that at 16 weeks, they were 10.8 kilos. And you almost could have bounced them in like a ball into the clinic. Because after all, 10 kilos is the weight of a 1-year-old normally. And these children, this child is typical. They've got sort of slightly spade-like hands. And they're quite puffy, and their feet, they've got a high instep, they've got short feet, Again, a very typical appearance. They have renal problems and they go into renal failure. They have eye problems, quite significant eye problems that need attention. And they have increasing obesity because they fail to feel satisfied after food. And so their obstructive sleep apnea gets worse and worse. So if you are going to operate on them, you need to do it early and you need to recognize them so they can be linked in and looked after by the appropriate specialty. This is another one where it could affect prognosis, and I'm hoping you all worked out this is a Gregg syndrome. So they're very typical. This is very typical in so much as they've got broad thumbs, they've got post-axial polydactyly in the hand and pre-axial polydactyly in the foot and some syndactyly. And they've got this frontal bossing. I always think they look really attractive because they've got this big forehead. So if you see someone that looks really attractive, that might be it, particularly if they've got post-axial polydactyly in the hand and pre-axial polydactyly in the foot. This is due to a mutation in GLE3. However, although they talk about intellectual disability with Gregg's and they say and seizures, they're not necessarily going to have either of those, and they may be entirely normal. But a differential diagnosis is Pallister-Hall, which also has GLE3 mutations. Now with Pallister-Hall, you've usually got more syndactyly, more camptodactyly, but they have significant problems with learning difficulties. They have renal problems, they have chest problems, they often have a laryngeal cleft, and they have seizures, and it is important to differentiate them. One of my colleagues I know has come across one of these, and this is an important one because Timothy syndrome has very subtle differences in the face and often has simple incomplete syndactyly. So it can go to any local hospital because they're not going to expect anything wrong. But that's really worrying because these patients usually have a family history of sudden death. And indeed, they have a very long QR interval. And with that very long QR interval, so QT interval, they have a risk of torsade de pointes. The torsade de pointes is highly resistant to treatment, and you have a risk of an on-table death. And that's something that none of us want to be in a situation like this child has got, where it says our dreams lie buried here. None of us want to bury any of the children that we treat. Other risks of anesthesia. There's a whole host of craniosynostosis that have risks for anesthetic because most of them have airway issues. And some will have obstructive sleep apnea as well. In fact, the Apert syndrome also have central apneas as a possibility. So they have central apneas, they often have choanal atresia, they have a mid-face hypoplasia, they have obstructive sleep apnea. You just wonder how their airways ever work, and indeed some will need tracheostomies. Now with the Apert, you're going to get this mid-face hypoplasia. So they've got sticky out looking eyes, proptotic eyes, they've got hypertelorism, they've got a dish face type mid-face hypoplasia, and then they've got multi-digit syndactyly on all four limbs. Apex is more common with increasing paternal age, and there's two main mutations of the FGFR2 gene on chromosome 10, and one is inclined to have cleft lip and palate associated, or cleft palate associated with it, and that one on the whole has better hands, and then the one that doesn't have on the whole has worse hands. And they used to say good hands, bad face, and vice versa. It's not entirely true, but it's a little bit that way. So Aperts, as I say, have all sorts of problems. You can name a system and they've probably got a problem with it. And that includes hearing, visual, cardiac, gut, kidneys, lung. As far as your hands are concerned, there's three main types classified by Upton, but there's certain things that are the same in all of them. They all have a short radially deviated thumb. They always have symphalangism, which means their joints don't move. So they only move at the MP joints, their IP joints don't move. And they have multi-digit syndactyly, which is always complex in the third web and is simple in the fourth web. Pfeiffer's look very much the same when you look at them in the face, but they have likewise broad great toes and thumbs, but they usually have incomplete simple syndactyly. They sometimes have some clinodactyly. They will have some symphalangism, but not to the same degree, and not as much syndactyly. And they'll sometimes have a radiohumeral synostosis. They'll sometimes have duplications of their great toe. And they often have really much more difficult airways, but intellectually usually on a better level. The Cyperchop patients, we don't see so much. They have shorter fingers, they have very long thumbs, they have a single crease, and we may see them about their duplicated great toe, and often syndactyly, which is usually simple and incomplete in the fourth web. And that's a mutation in twist1 transcription factor. Carpenters, which is the only autosomal recessive, all the rest are autosomal dominant. They have brachycephaly and they can have extra digits, they can have syndactyly, they can have bent digits. They get optic atrophy, they have cardiac and renal defects. But these ones, I think all of these are much more likely that you're going to be able to spot there's something different about them because of their craniosynostosis. Golden Haars is the next one. And thinking about, like, you're thinking about hemifacial microsomia, you're thinking about patients with epibulbar little lumps there, and often microtia, and this is an ear with microtia, so the ear hasn't developed properly on the one side. Now these will often have difficulty with intubation because they may not be able to open their mouth because their temporomandibular joint is often not well developed, and they've often got thumb hypoplasia or thumb duplication. You will get some of these syndromes where you have long, lax fingers, and one of them is a Spritzing Goldberg syndrome, which has also got problems with the head and eyes and often visual issues. And they have learning difficulties and they have joint laxity, but at the same time they'll have contractures. And they have arachnodactyly, so they have very long, thin fingers. Then you have Antley-Bixler syndrome, where they have funny ears, again, long fingers, often have synostoses, radial ulnar or radial humeral synostosis. Another one to think about in terms of anesthesia is Fraser syndrome, and these patients may be blind. They may not survive beyond a year. They've usually got learning difficulties. They've usually got some sort of ophthalmic issue, and you can see the eye is not normal here. And they'll have genital, renal, and ear issues. But they also sometimes have problems with the larynx, so they may be difficult from an intubation point of view, and they certainly need to be seen as far as their kidneys are concerned. Freeman Sheldon syndrome may appear easy. These are the ones that have distal arthrogryposis with windswept hands, so they have ulnar deviation of their hands, of their fingers at the MP joints, and they have a little pinched in face, a whistling face, and they're micrognathic. So they can be a difficult intubation, and they always need a small ET tube if you're going to put an ET tube down them. I said I'd mention TAR again, and TAR syndrome. The issue with that, these patients are unusual in the radial ray deficiencies because they have thumbs. They're not normal thumbs, and in fact, Chuck Goldfarber's done a whole article on them. They're a bit flat and wide. They're not normal. They often haven't got an IP joint that functions, but they do function as thumbs. They're stable enough to do something useful. And TAR syndrome patients start with severe thrombocytopenia that improves usually by the age of 5 to something you can operate in, sometimes earlier. And if you can get them centralized and stable, they'll often function quite well. Now, some TAR syndrome patients won't need surgery. They may be almost phocomelic. And the other really relevant thing is a lot of them will have lower limb problems that are significant. But certainly you don't want to be diving in, not realizing that these patients will have a thrombocytopenia, because you will cause problems. And then you come to, what's the prognosis for a good surgical result? Because obviously when we operate, we want to get good results if we can. Now, split hand, split foot, or cleft feet, cleft hands as you think of them, was described as a functional triumph and anesthetic disaster. And here the family may influence your decision making, because there's often a family history and they may already have a strong idea of what they do or do not want done before you see them. But you have to remember here that they work well, they just look awful. And so whatever you do, you've got to really think about whether it's worth it and whether you're going to make them worse. One situation where it's particularly difficult is when they've got a lower limb deficiency as well. And there is a group who have split hand, split foot syndrome with long bone deficiency, and they can be really difficult because they may need prosthesis, particularly if they end up with an amputation. If they do end up with an amputation, the other question is if anything from that they're going to be amputating is going to be useful on the upper limb, because there's often a significant deficiency there. But you've got to weigh these things up. This child may end up using crutches some other time. Are they going to cope? Are they going to be better with or without your surgery? Another group that you get with clefts is the Eecs, where they have ectodermal dysplasia, and they have eye problems, they have teeth problems, and palate problems, along with hearing loss. Another group that you've got to think about who don't have other problems, but will cause you problems as a surgeon, are the sim polydactylys. And these are due to a HOXD13 mutation. And on the hand, you'll usually get an extra digit between the middle and ring fingers, and on the foot between the 4th and 6th toes. And the foot isn't too difficult, but a hand is a complete nightmare. And usually the vessels are abnormal here. In fact, they can be very abnormal with just one vessel for 3 fingers. Embryologically, I'm sure we'll tell you, there's some evidence that they have not such good primary vessels, but have quite a good vascularity coming in from the sides as such. But they have abnormal tendons and joints, and it's really difficult to get really nice results with these. It's quite normal to end up with stiff joints with deviation, and it is quite difficult to get a really good result. So don't promise too much there. The triphalangeal thumbs work pretty well. They look more like a finger, but you can get some good results. However, as has been shown by the unit in Rotterdam, even though they look good and they seem to work well, if you look subtly at them, they have subtly different function from normal thumbs. And that's even the ones that haven't had reconstruction. And then there's some patients where really you're not going to win. Cheyne lens syndrome, I've only seen a couple of patients of it. It's a pretty rare disorder. But you have multiple carpal and tarsal coalitions. It's really difficult to get anything that works. And when you do get anything that works, it's a pretty crude sort of grip that you get with them usually. And I can't say I've seen any really brilliant results. There's some sort of not too bad considering results, but that's the best you're going to get. If your anatomy starts like this, you know, we're not God, we can't make a miracle. And then you have ones like Laura and Sandro, where you have polydactyly. You may have 9-10 toes on each foot, 7 fingers on the hand, no thumbs. And they also have nasal abnormalities, and they have corporal callosal abnormalities, which means that they're unable to switch hands so well. So for instance, on this one, the left hand's got lots of flexion contractures, but if you get a good result on a policization on the left hand, that's great, but it's never going to work as well as if you get a good result on the right hand, but they're not going to be able to compensate from one to the other. It is important in knowing if you've got a syndrome, because it may alter the prognosis for surgical intervention. And then when you are assessing outcome, you need to group different conditions together that are appropriate to do so, so that you are comparing apples with apples. Remember, things such as the APERT syndactyly always have slower wound healing, probably related to their sweatiness. In TAR syndrome, you have functional thumbs. So on the whole, their function's going to be a little bit better than their compatriots with other forms of radial dysplasia that don't have functional thumbs. And on the whole, most series have shown in policization in syndromic cases doesn't do as well as isolated. It certainly doesn't do as well when you've got a more proximal radial deficiency. I just want to mention a couple of other conditions because I can't talk about everything. PIC3CA related overgrowth. Now, it encompasses loads of conditions that we used to name in all sorts of other ways, including lymphangiomatosis and cloves, macrodactyly, and there is now the possibility of using mTOR inhibitors in some of the worst affected, and there's still a lot of experimental work going on with that. Proteus syndrome, you've obviously got an AKT1 kinase mutation, and they get lots of fatty lumps appearing elsewhere. They get overgrowth, particularly their feet, and very typical appearance with vascular malformations as well, which are often capillary-like appearing. And then for the orthopedics, so within the Ollier's disease and Maffucci's. Ollier's is multiple enchondromata. Maffucci's, you have venous malformations associated with them. And they've got mutations, these are all post-zygotic mutations. So it's not affecting every cell, but their mutations are related often to later malignancy. And then there's those things that aren't considered genetic. So Vacteral, I've already mentioned vertebral, anal, cardiac, tracheoesophageal, renal and radial deficiencies, the LB and limb. And these were originally not considered to be genetic, but now there's a thought that they are related to one chromosome, but we haven't got a locus. There's amniotic band sequence, which is not genetic, but it can be mimicked by Adams-Oliver's syndrome, where you have a cutaneous defect in the head, as well as very similar looking defects in the limbs. And then one of the ones you'll probably see most commonly is Polans syndrome, which has a pectoralis major absence. And it's the sternal head that's usually missing. Now, occasionally it'll be both heads, occasionally it'll be ribs missing. But more commonly, it's just a muscular, either deficiency or complete absence of the sternal head major. Lat dorso might be missing, teres might be missing. The breast, the nipple is hypoplastic and usually displaced, and the breast may not form. That's relevant for both sexes, but particularly women, obviously. It is associated occasionally with Mobius syndrome, where you don't have normal formation of the facial nerve. So they all look a bit miserable because their face doesn't move. But more commonly, you see this in brachydactyly, particularly the short finger type brachydactyly. So you're probably going, oh, when's she going to stop? I can tell you there are miles too many syndromes to remember. Try and remember those that are important, that are going to impact the family, that are going to impact your anaesthetic, and which are going to impact the result. When in doubt, return to basics, strip the child off and examine them thoroughly. Look for those signs that are just a little bit off the wall from normal. The more limbs that are involved, the more likely the condition is genetic. And if you've got a geneticist, please use them. Be cautious and careful with planning surgery if you can't work out the puzzle for yourself and work out what's wrong, even though you can tell there's something wrong, because you don't really know what the risks and the anaesthesia are, and you don't really know how your result's going to be. So thank you. I'd appreciate it if you don't use this to spread it around the internet any more than it already would be. It is a teaching presentation. Thank you.